Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for the second season of conversations aiming to bridge gaps surrounding dysphagia intervention. Swallow the Gap podcast is a production of Gap Education, and we are predicated on a mission to improve dysphagia care. Nothing we say is legal advice, nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, therefore our guests will not always reflect what we believe. In fact, we may change our minds as we learn more because this is how progress is made. Through critical reasoning with open minds, we serve as catalysts for advancement in medically focused speech-language pathology. This episode of Swallow the Gap is sponsored by Bracco Diagnostics. Bracco is the maker of Veribar barium sulfate, the only contrast validated for standardized, well-tested protocols during modified barium swallow studies. For more information, visit veribarmbs.com. Welcome, everybody. Today, Dr. Kendrea Garand has joined us, and we're going to talk about some cranial nerves. A little bit about how to supplement your clinical swallow or your instrumental swallow evaluation with information from cranial nerves, because in my opinion, if you're not tapping into that, there's a lot that you're missing out on. So with that, just turn it over. Thanks for coming. Thanks for joining us again.
Yeah. It's I love talking about this topic. As if you ever heard me talk about this topic, I'm very passionate about it. And it's so interesting because it actually stemmed from me being called out for not knowing it by an oncologist when I was a doctoral student back in the day. And, it's something that we learn about, but I guess I just didn't learn it deeply enough or enough to recall it off the top of my head sitting in front of a patient. And so that kind of spearheaded into me kind of relearning them and thinking about ways to teach other, clinical students of ones that I was supervising, and then one day actually, teaching entire cohorts as they go through graduate school. And then thinking about how, not everybody is earning the same education related to how the cranial nerves are taught and the underlying neuroanatomy, underlying neurophysiology. And then I think the biggest gap is I think we're doing a lot better about teaching how to perform a cranial nerve exam, but maybe not what to do with that information all the time. And so, we still see some questions even on Facebook of like, are y'all performing cranial nerve exams? Why or why not? I don't think it's necessary every time. And if you've ever seen a lecture or been a student of mine, our saying is every patient, every assessment, every time. So even if it's specifically for COG-COMP or aphasia or other language disturbances, motor speech or swallowing, I'm always doing a cranial nerve exam.
Yeah, that makes sense. There's a lot that it can tell you. And I mean, like for this, I'm looking at it particularly through the lens of dysphagia, but of course, that and motor speech. I mean, so it's taking a step back. I taught a motor speech disorders class back in the spring, and Kendrea helped me a ton. And your material was so valuable. I learned so much going through that course. Like I probably learned more than my students did. It was really good. Like I thought I knew a decent amount about motor speech disorders, but looking at the underlying neurological bases for so many things was just incredibly helpful to me. And sorry, but to go back to what you were saying, you mentioned that you initially kind of got into this more because you were called out for it, right? Okay, so I'm going to take a step back. And I remember when I was very early on in clinical supervision that a student was asking me about the cranial nerve exam. They were asking me about the cranial nerve exam, and I was happy to cast it through the lens or to teach it through the lens of what I knew as far as cranial nerves go. But this was my perception at the time. I'm fairly certain that I told them it's like, basically you're doing an oral mech exam and speech pathologists say they're doing a cranial nerve exam to look kind of pretentious. That was my perception at the time, that we called it that, but we weren't really looking at cranial nerves. We're looking at how the lips seal, we're looking at this, but there's not that level of integration. And I think one of the reasons for this is because, that is to a degree, and I'm not gonna paint broadly, but that is how it's used in some areas. We might call it a cranial nerve exam when it's not. But also, you think about the level of integration that's needed to come out of grad school knowing this. I think you said that sometimes, just a couple of minutes ago, you said that we sometimes, oh, what did you say? Know what we're doing, but not why, or know, oh.
Yeah, or just how to use that information that we're gleaning from it, right?
Yeah. Oh, maybe it was how to provide the examination, but not necessarily know what we're taking away and what that
Right.
means with swallowing or motor speech or whatever. And so that's what I kind of want to touch on here a little bit. And I realize we can only do so much within 20 or 30 minutes. Having said that, Kendrea has agreed to do a recorded course sometime later. We don't know exactly when that's going to be, but I'll keep you all posted when it is. And I think you have some courses out there right now, so if people don't want to wait, they can probably find that information too. So with this, first of all, I'm going to ask what I perceive to be a very basic question. Which cranial nerves for swallowing are the most important for us to assess during a cranial nerve oral mech exam? Back to elementary school.
Yeah, so I do half of them.
Okay.
So my kind of standard, and we can talk about standardization and the importance of that. But definitely my typical examination is going to include 5, 7. I'm going to clump 9 and 10 together because you can't really assess 9 so separately. And because a lot of those fibers are traveling with 10, I'm just going to clump them together, 9, 10, and then 11, and then 12. So half of them.
Mm-hmm.
Sticking with the pons and medulla from coming out of the brainstem. And that's how I teach my students or newer clinicians or even more wiser clinicians that just feel they need to brush up. And I start by teaching by the cranial nerve. For me, if you're not watching me, if I'm behind closed doors and doing my own clinical thing, I typically go by structure then. But I think to really learn what nerve is innervating what and what movements and what sensation are being provided by that nerve, I go by the nerve first. So I joke around with my students, when I give them my standardized protocol, I give them my standardized report and how to write it up and bringing in evidence to support your findings. Then I always say, you have to carry this around for at least 3 years post graduation, and then you can throw it away and then you can do it your own thing. But then I typically go by structure because I think one of the most amazing things is, and the tongue is the best example of this, is you have this one structure, right? And a lot of times, and I remember talking about with Dr. Vos and Dr. Humbert doing their podcast and talking about cranial nerves, is there's a lot of focus on motor, right? And sometimes we ignore that very important sensory part. And you were talking about motor speech and sensory afferent information is really important for motor speech production, but also for swallowing. And so you take the tongue, for example, where you have the movement being provided by 12 and one extrinsic provided by 10. And then you have general sensation being, provided by 5. And then you have taste sensation being provided by 7. And that's just the oral tongue. Then you have the back of the tongue. And that's sensation is, by 9 and general and taste. So it's this one structure has, how many did we say? 5, 7, and 9, and 12.
Mm-hmm.
So 4 nerves. I mean, that's just insane to me for one structure. But the tongue, if you think about it, is so important in swallowing and not just for, the oral domain, bolus prep, containment, etc. And then also the transport piece, but it's such a big pressure generator, not just through the oral cavity, but also through the pharyngeal cavity as well. And so really important, even getting that onset of the pharyngeal swallow to occur. And so And no wonder it has so many nerves because it's a really important structure related to swallowing. And so long-winded answer to answer your basic question. So I teach 6 of the nerves.
Okay. It's interesting how you lumped 9 and 10 together. And that's actually one of the questions that I was thinking about before coming into this. So I do something very similarly. I'll look at 5 and I'll look at it from the motor perspective of the jaw. And then I'll look at it from the sensory perspective of the ophthalmic branch and the maxillary branch, the mandibular branch of the trigeminal nerve for facial sensation. And of course, the mandibular branch being both motor and sensory. And then I'll go to the facial and I'll look at the upper face and the lower face. So you can kind of tease out, well, is there an upper or lower motor neuron issue? Maybe, whatever, depending on how that goes. And then I will look at 10. I might look at 10 as far, 5 and 10 as far as soft palate movement, but listening to their voice. I like to go through breath support as well, too. And then, of course, looking at the tongue for the hypoglossal nerve. But I have 9 is a little bit of an enigma to me because I've always thought of it from the perspective of the glossopharyngeal nerve is almost all sensory, right? But of course, what is it? I'm going to mix this up because I'm on the spot. The stylopharyngeus or the salpingopharyngeus, whichever one of those longitudinal pharyngeal muscles that it innervates from a motoric perspective, or at least that we were taught that it innervates from a motoric perspective. I don't know how to test that for swallowing. I mean, I can test the gag and get maybe the sensory component of it, but a lot of people don't gag anyway. So yeah, there's a lot there. But so you were talking about these 2 nerves coursing together. I'd love to hear a little bit more about that and maybe some of the limitations that presents to us in this.
Yeah, more so I'm talking about the palate in particular, right? And so I'm thinking about, the pharyngeal plexus and kind of lumping those fibers together and how that's traveling. And part of that is providing, the the innervating the pellet and like the the upper pharynx. And so that's what I mean when I'm talking about like 9 and 10 together. And so, but you going back to the point about the sensory and the motor thing, you brought up the gag reflex is, but there's an absent of a gag reflex, you're right. So could it be that's just their typical behavior outside of any kind of neural insult? But an absent gag reflex may mean sensory impairment. An absent gag reflex would mean that they felt it, but they couldn't produce a motoric response, or maybe it's a combination of both. And so it is, and that's the fun yet really aggravating part about diving into neuroanatomy and neurophysiology and managing patients that have these variety of neurological pathologies that can be quite complex, very diffuse, and most of them are idiopathic, and we have no idea why they're occurring. And so, but it also makes it's fun because then for me it is like playing house. For an old reference, I had my students tell me that I need to have more updated Hollywood references when I try to think of it, but it's like being house. It's like trying to figure out what it is and what's causing it. And I think with some of our, most of our cranial nerves, or the ones that are related to swallowing, are these mixed nerves, right? They have both the motor and the sensory components. But and sometimes that can be difficult to tease apart too. Even if you're asking them to do a motor component, so you haven't then complete a motor task. There still is some afferent information happening in that background, right? Of like where the structure is in space. Did they reach their target like they wanted to? Were they aware that they didn't reach their target if they didn't? And so sometimes I think that can be hard to separate as well. And thinking about, I know going back, you said, like oral mech and then cranial nerves, it's like, what do we call it, right? I do call it a cranial nerve exam, but I realize I'm testing more than the nerve, right? The nerve is just the final common pathway. That's your lower motor neuron pathway, right? And so, but the the issue can be at the muscle itself. If we want to think about a muscle disease like inclusion body myositis, it can be with the nerve itself. It got resected, it's inflamed or whatever it is. We can talk about the neuromuscular junction. We're talking about something like myasthenia gravis, so a postsynaptic in a neuromuscular junction disease. We can talk about the actual nuclei itself in the brainstem that are damaged. We can talk about the cortical bulbar tracts coming down to innervate the nuclei within the brainstem. So any one of or the motor, the motor strip or the association areas. So it's like any of that can impact. Then we have the extrapyramidal system, right? We have the cerebellum and the basal ganglia and all those helping modulate the environment so that these movements can occur on top of. And so it's like all that is so complex. And then, so we call it the cranial nerve exam, but it's much more, right? Entire sense. Thing.
Yeah.
I don't know what to call it. I don't know what the best name to call that would be. And you had the sensory and the motor pieces.
Oh, no. Yeah. As far as that goes, I've learned to call it like multiple things. I'll say the cranial nerve / oral mech exam because it's trying to get information on both of those. But you're right. You're looking at so many other things. I mean, don't get me started on the extrapyramidal tract. I feel like that is the most shallow area for me and neurology related to this stuff. And so I'll probably pick your brain a lot more on that later. But I believe that you've kind of brought something to the surface that we have to become comfortable with. Is there's so much that's gray within this. So going back to the gag reflex, I'm talking about, it's integration between cranial nerves 9 and 10. The glossopharyngeal nerves should sense something, and then the vagus nerve should cause this contraction. And so when you test the gag, it's these two things working together. And so if you don't see a gag, one, maybe it's their baseline. They just don't have a gag. 2, maybe it is an issue with afferent glossopharyngeal nerve, or maybe there's this motor issue with the vagus nerve, right? And so for me, I've kind of have backed away from testing that, but now I'm thinking about it again. It's like, okay, I still ask them to smile, even though I don't know if they have some slight asymmetry. Maybe that's their baseline because not everybody's face is completely symmetrical. And I found myself doing that a lot in exams, saying there was, some probable asymmetry, but it's unknown if this is representative of their baseline or if it's, within a pathological range or whatever. So I guess what I'm trying to say is that for me, I need to reconsider what I assess as far as the gag reflex goes, because there's so much of this, layering and triangulating of information where it's not always black and white, where this doesn't always equal that. You test the tongue. Does that mean that there's an issue with cranial nerve 5 or with the hypoglossal nerve or with something else? And we might not know. But considering it at least gives us somewhat of a platform to be able to form a hypothesis. And it also gives us some information that we can triangulate with other information to try to get a best answer. I don't know. Do you think that's valid?
Oh, I love that. And I love that leap. And I think that's a very natural progression of how we should always be thinking about the exam. And that's why I do it on any patient. And that could mean, I started out in inpatient rehab and then also covered acute, and then went to like a typical outpatient at a university hospital, and then also covered acute, and then moved fully into outpatient specialized clinic, with a motor neuron disease clinic, and then moved into a university-based in-house clinic, which is also very different, where our diagnostics were 2 hours long. I mean, I could do whatever I wanted to with them, right? Versus acute care where, you might have a nurse coming and saying, we have to take them on a CT in 5 minutes. You have 5 minutes to do what you need to do. And so, but in outpatient, sometimes it would be, I'm walking into the radiology suite, and that's the first time I've ever meeting this patient. And so it was really nice to do a quick cranial nerve exam and then immediately be able to tie that in versus being, in a specialized ALS clinic where I can refer for a modified. So I did my cranial nerve exam as part of their, my screenings that I do, but it could be a month or 2 months,
you don't know what's changed since then.
Now we have this kind of time gap. And for ALS, 2 months can be, pretty quick with regards to a change in status. So And I feel like we do a better, or I hope we do a better, or maybe do a better job. I don't know what the quantifier would be. Is, when I teach about the clinical swallow exam, if they're doing swallow trials, like linking that behavior to what they see on instrumental. But I always also always link it back to every other piece of my clinical exam, right? And that includes a cranial nerve exam. And I'm about to go on like two side tangents here. So bring me back if I start going down. Um, but I think that's really important because when I'm doing my cranial nerve exam, and I think we all are, because we all are scientists, really. I mean, we are collecting data. But I think what takes us a step further, maybe as something that's a more dedicated researcher, is our dissemination of our data, right? But clinicians are always collecting data. And with that, we can start forming hypotheses. So when I'm doing my clinical exam, with the luxury of doing that before my instrumental, I already have my hypothesis of what I think I'm going to see on my instrumental. But there's a good point about bringing it back. Right. And so a lot of times we're like, well, they didn't cough, during their clinical, and we saw them aspirate, so they're selling aspirator. So I think we do that kind of going back. But I also would like to bring it back to the function that I saw during the exam then, right? And so you'll see this in my impressions in my report.
I'm just bringing you a brief interruption that helps to keep this podcast going. I'm very thankful that Bracco Diagnostics is sponsoring this episode of Swallow the Gap. Bracco is the maker of Veribar barium sulfate products, which are FDA approved and the only premixed, pre-measured, and precise barium products for modified barium swallow studies. For more information, please visit veribarbmbs.com. That's VARIBARMBS.com.
And actually put my impressions is actually my first paragraph. I don't do the typical where you start with the history and stuff like that, because so I like to bring my impressions right up, but you'll see me link. So if I say, involvement of, let's just keep it to the tongue, since apparently that's my favorite structure for the night, is, involvement of hypoglossal characterized by, and I'll say whatever is tongue deviation upon protrusion, or, reduced range of motion, whatever I did. And maybe I'm bringing, more objective measures, like maybe I had the IOP with me or whatever it is. But then I tie it back to, this may correspond to the patient's complaint that they have food remaining on their tongue and they need to have a liquid wash to clear. And then say I bring it back to the modified, or I do some kind of, let's keep it to the tongue. So let's talk about the modified. And then I'll bring it back to what I saw, oral residue. This is consistent with blah, 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 blah. Right. And always bring it back, because then I just tested my hypothesis and now I'm building up my clinical experience, right? My toolbox that I'm always using and going back, because what do I expect to find? So now my hypotheses in the future are even more informed if I have a similar patient, because I've seen all this data, right? I'm increasing my power, if you will, because my sample size is increasing because of the number of patients I see. Now, I can always be wrong, right? That's why we never prove anything. We always talk about supporting, right? And we can refute, but we never definitively prove our hypothesis, right? That's when we're talking about theories and paradigm shifts in thinking, in scientific thinking. But I'm just saying, like, you know what? Okay, now I'm getting a lot more data to support this. And so I think that's maybe the missing piece when I see some of these comments on social media with regard to, why are y'all even doing it? I don't understand it. Why does it matter? Kind of thing. Is I think they're not taking the step back to see the whole forest, because it all goes back to what that patient is bringing to us. And this actually this is my second sidestep, is this got brought up in another clinical example I had, of ALS clinic that I was at. We had a lot of turnover in attendings, and the attending that was there actually for many years and even stayed on after I had left. She, we're always cognizant of, we have a lot of patients to see, and we had like 14 providers that had to see one patient, and we're constantly moving, and ALS has a real issue with fatigue, and they get tired, and it can be overwhelming emotionally, and physically overwhelming, and also a lot of burden on the caregivers at sometimes. And so, we were always looking at efficiency and who was doing what and how we can get these patients in and out. Because typically everybody else had afternoon clinics to get to, because it's just a morning clinic. And so she kind of asked me, like, hey, why are you doing a cranial nerve exam. Like I already do one. And, we need to be efficient and think about that. And so I said, I get it. Like, I understand. I wasn't taken aback. I wasn't defensive or anything. And I was like, this makes sense because she is coming in for like, I'm thinking about what's best for our clinic. And I'm definitely thinking about what's best for our patients that are in the clinic. And so I sat down with her and I actually showed her my data collection template and then also showed her example of like how I write my report and put in the framework of like, you are rightfully so looking at your results from a neurology lens. I am looking at this from a speech pathology lens. And so my functional outcomes are related to breathing and swallowing and communication and the intimate relationships between all of those, right? And so I was like, I'm looking at those as the functional outcomes, right? Like I'm not trying to tease apart that this definitely shows a lesion in this particular area that was caused by this and, whatever. And I have that background knowledge, of course, and that can help me in my differential. But I said, I'm really looking at this from this lens. And then she was like, okay, keep doing it. And it was, and so that was great because when we would talk, when we would debrief after a clinic, then all of our perspectives was coming in, right? Like we were seeing, if you go back to that, the cartoon where everybody's looking at the different parts of the elephant, they all think it's a different, thing. And so we all had those different lenses, but we were able to always come back at the end, which is why specialized clinics probably have the best outcomes, is because now we're all looking at it from a holistic perspective, almost each providing our expertise in order to understand that picture a lot better, taking that kind of stance back.
Yeah. Wow. There's a lot there. There's a lot there. And I appreciate it. I appreciate, looking at the same thing, but through a different lens. I think that's very helpful. In fact, this episode will probably come out after one where I really talked about swallowing in terms of function. And so like for that, the idea is we look at, just aspiration is the easiest one to throw out. We look at aspiration, but through what lenses are we considering that? Are we looking at it, well, I'm afraid this patient's going to asphyxiate because maybe they're aspirating, not chewing up their peanuts and they're aspirating entire pieces of, nut. Or is it maybe they're going to get pneumonia because they are immobile, they don't have good oral hygiene, whatever. Or maybe they're not at high risk for either of those things, but they just clear their throat all the time and they hate it. It bugs the crap out of them. It just annoys them. They're like, I don't want to have dysphagia because I'm at a social outing and I'm constantly going, clearing my throat and people are looking at me weird. It could be a number of different lenses that we're applying to the same thing that we see. And so I appreciate that a lot. And I think also sometimes we like to have just clear-cut kind of formulaic answers like, oh, if you see this, then it's that. Like, the one that I like to harp on, and I will throw this out there as a challenge. Like, please, every time you see residue in the vallecula, don't say it's because of reduced base of tongue retraction. Because how many things can cause there to be matter that's left in the vallecula? That might be the one that explains most scenarios, but it's not a formula. You've got to look at so many other things. And so we're running out of time, which this is not like a topic for a 30-minute episode, but we're going to make it fit. We got to make it work. What do you think is one of the most important things in terms of differential diagnosis of dysphagia that you can use, that you can derive from your cranial nerve exam? So like if you see XYZ on a modified barium swallow study or on a FEES or whatever, and maybe it's ambiguous, you're like, well, it could be this, it could be that. How does then our cranial nerve exam bring in this extra information that maybe is going to help us to be able to bring a better outcome for our patient?
Yeah, so I think the cranial nerve exam can better inform you of what you're seeing on the modified. So a modified, I can't, because the structure is not moving. I think a lot of us will be like, oh, that's really flaccid, when it could actually be spastic, and that's why it's not moving. So now we're talking about different pieces of our nervous system that are impacted. But you could appreciate that then during your cranial nerve exam, right? I can see the vesiculations of it maybe on the tongue that maybe indicate lower motor neuron, or I can hear that their voice is really strangled, indicating a more spastic influence. And so I think all that can be tied together. And I also think it's really good because then it goes back to function, which is what we were bringing up earlier, because I can see maybe a tongue deviation that's slight that would suggest that there's some neural involvement. But when I get them in the modified, it's not impacting their function. And so it's bringing that all back as well. And I also think it forces us to help start thinking about everything's going to be on a continuum. It's not this binary normal, abnormal. It's way more complicated. That's how I write it up because otherwise it's really confusing. And there is like a cranial nerve exam that's published at INI that actually does like an ordinal scale, almost like the NBS IMP does for the components. They do a description for each score and do the key cranial nerves that we've already been talking about. But I think with the understanding of that, though, is almost kind of going back to what you said, like maybe that's normal. And so I always encourage my students to make sure you are giving cranial nerve exams on your grandparents, your younger cousins, or your significant others, 2 a.m. outside of a bar, get some practice with some ataxic dysarthria that's happening. But like, it's a great way for you to start building up and really, because I think I'm mostly, if you're not used to the cranial nerve exam, like a lot of us do, like when we're learning how to do fluoros, is we overdiagnose. Like we see a little bit of residue in the molecule is a perfect example. And we're like, no, man. Like, oh my God, they have cranial dysphagia. And when you've been like, me, I've seen hundreds of healthy swallows, non-dysphagic swallows. So my pendulum has kind of swung back. Hopefully more in the middle, but maybe even to the extreme then where I'm like underdiagnosing maybe. But yeah, so I think the cranial nerve exam then can help, again, postulate what you might be seeing because we're not seeing what's involving the pharynx. Allows you to test the hypothesis, but also will allow you to already think about your compensations that you may apply. That's why we test 11. If 11 is affected, they can't do a head turn, then I know I'm not going to test that in the fluoro suite because they can't do it, right? And so you can already start getting you thinking about if you're going to apply some interventions, what would actually be appropriate for that individual patient based on their diagnosis. And that's if they have a diagnosis, that's the one great thing about, again, that's kind of really forced me down this realm and spent so many hours learning about this and still learning, is most of my patients don't have a diagnosis when they see me, right? They may have a differential somewhere, but that's where we're seeing them, or we may be the first to see them. And so I saw a patient when I think it was a postdoc at this time. She was referred to me for a voice, and they were thinking she was older, so they were like, "Oh, yeah, she's an older lady. She probably has maybe some prosophonia going on." And then I'm doing my exam, and her husband keeps bringing up the memory, and he was like very pertinent about like making sure that I understood. Not pertinent, that's not the word I'm looking for, but making sure that I really understand like that she was having some memory issues. So then I kind of switched course, and I had already done a cranial nerve exam, but then I threw in a cognitive screen, and then I did some reflex testing with her. And she had these 3 frontal release signs or positive signs kind of indicating maybe there's some frontal lobe dysfunction going on or some kind of diffuse involvement. So then I immediately referred her to neuropsych, and she ended up with a diagnosis of Alzheimer's. All because of this because of my cranial nerve exam. Right. And yes, the patient complaint, but it's just, if we don't know why we're doing something and we don't really gain the meaningful information, we are selling ourselves, our profession short. And I think we're, to be so blunt, doing a disservice to our patients, obviously. And that escalates to the entire healthcare system, right? Because now we're kind of wasting resources. So, okay, another tangent.
No, that's great. That's great. And I'm in just a moment, I'm going to kind of ask you, hey, is there anything else that you want to touch on? Because we'll be done here in a couple of minutes. But one of the things that one of the things that I love, and I think is a good example of this, is if you're looking at bolus control, and you were already talking about the complexities and the nuance of the tongue. So if somebody has issues with posterior bolus containment or lateral bolus containment or whatever, not that posterior spillage of the bolus from the mouth into the pharynx is necessarily deviant or even abnormal. But say maybe for whatever reason, there's a reason to treat it, right? Not acknowledging the sensory motor interplay that's going on. Like I compare it to trying to hold a ball, like trying to flatten your hand, almost like bending it backwards and trying to hold a ball in it. You've got to adapt to where it's rolling. And so the same sort of thing kind of with the bolus, a liquid bolus or whatever on your tongue, like, okay, cranial nerve 5 is providing some general sensation. And then the hypoglossal nerve is going to these different muscles, intrinsic muscles of the tongue to cause it to cup and shape in a different direction and move and that sort of thing. So like if you just treat it as something that's, this patient had posterior bolus loss and it commonly caused them to aspirate prior to the swallow or whatever happened. If you just treat it from a motoric perspective, like, well, what if it had nothing to do with motor? What if it was totally sensory and without the cranial nerve exam, you wouldn't know that, or you wouldn't have information to kind of lead you in that direction?
Right. And that's why sometimes I think, unfortunately, we assume motor and then you give a patient just like a larger bolus volume. So you're not changing taste, you're not changing temperature, you're not changing anything else. That larger bolus volume that I think some clinicians can actually shy away from. And I know sometimes I did it yesterday by the radial. I was like, we were doing larger volumes and I could see the radiologist like being like, do you see the dysfunction she's having? I was like, give it a second. And that larger bolus volume worked better for that patient to actually help clear. And so, yeah, so I think that's a wonderful example to really bring up. And again, it goes back to matching the intervention with your impairment. And so if you're doing that cranial nerve exam, you're getting that information. Again, you have your hypotheses and well-formed hypotheses, which is what hypotheses are. They're not guesses, right? Or not pure guesses, educated guesses. And but when you're in the fluoro suite, again, now you're not just going down the alphabet of strategies that you learned in your the textbook. Like you actually have a clear rationale for why you're trying stuff. That's going to keep radiation exposure low. That's going to make your radiologist happy. And it makes I don't know, I feel like it builds and it builds your confidence. Like you're like, oh, I was right, kind of thing. But also just the confidence of our field and our ability to talk to patients. And I think it increases confidence in other providers and us and what we do, and especially in the patients that we serve. So I see no downside. Don't.
See no downside. It's funny when you do your job well, what that does for not just our patients, but the profession. So many benefits to it. Well, thank you again for coming on. Is there anything that there's a lot that we missed because we could talk about this for hours, but is there anything that you're like, I am not going to leave here tonight until I say this? This is your chance. There you go. Permission granted.
Yeah, I think we sort of touched on this, but I would just say, even if that patient has had the same stroke location as the 20 other patients that you've seen that month, and it's still going with a little bit of healthy skepticism to avoid you going down a wrong path, right? Because that's what you're expecting to see, right? And you can talk about it as being, confirmation bias. And we talk about confirmation bias a lot in our field. Because it may not always be the case. The last patient example I'm going to give is I came out of a meeting and my graduate assistant in our lab came out. She's like, Dr. So-and-so called you. He was a neurologist. I was like, why is he calling the lab? And she's like, he said, you have to call him back. It's like urgent. And so I call him back and he's like, you have to see this patient. Pretty sure she has ALS. And I was like, okay, we'll get her scheduled. He's like, no, you have to see her now. I was like, okay. And so here I am. I was told she has a diagnosis of ALS, and that's been my specialty for 15 years or so. And so, so I already have okay, I know what to expect or what I should see. And so I called her to set up an appointment. I get her voicemail. Her voicemail sounds very normal, right? She calls me back and I missed her phone call. So now I got to hear her new voice. And I immediately, with And without talking to her first, I kind of gave the neurologist a heads up. I was like, I don't think it's ALS. So we bring her in, I do the assessment, and then I called him back and I said, I was right. She has a hyperkinetic dysarthria. She has spasmodic dysphonia. And so we referred her to ENT. But I mean, can you imagine me like going down this road of like ALS and we're just doing my typical discussions about what ALS can do, and then finding that she can be treated with Botox and some like behavioral voice intervention. So yeah, so I would just say be cognizant, like, so definitely build up your, like I said, your data, your power and bringing in your own clinical experiences, but still have just that slightest bit of like openness to be surprised. And I think that's like the fun part. I don't mind being surprised, because otherwise every day starts becoming monotonous and we're doing the same thing over and over again, right? And I'm sure you can appreciate this because I know you teach. Every cohort's different, even if it's the same material, the way they ask questions, the way they interact. And so it's always like a new patient every time. Even when I'm teaching, it's a new patient in front of me every time. And that's what they deserve. I would love my loved ones to be treated individually, right? And to be given the due effort and time and experience that they deserve.
Yeah, for sure. There's a lot there, a whole lot there. Well, thanks again, everybody. Dr. Kendrea Garand of the University of Pittsburgh. Well, thanks again, Dr. Garand, for joining us today. If anybody wishes to follow up with you to pick your brain or to get information on one of your courses, what would be the best way for them to do that?
Yeah, I think email's probably the best way. It's probably the quickest way, right? Because phone's with me all the time. So that would be at kgarand@pitt.edu.
Okay, sounds great. Well, thank you so much. I'm looking forward to recording the course, the more in-depth course that we'll be doing later. But until then, this will have to do. So thanks again, and have a great rest of your week.
Thank you.
Thanks for tuning in to another episode of Swallow the Gap. Love to hear from you, so please reach out anytime. When you have a moment, share this episode with a friend or tell a colleague about us. I hope this episode has been beneficial to your practice and has sparked your curiosity.